come over here. So I manage myopia. I don't have all the answers. I actually have a lot of questions, and that's what I want to go. And I'm going to forward a lot of the presentation. I have 40 slides to cover in 20 minutes. I like to talk and I like to listen to myself talk. But I need to give you something, right? We really don't know what causes myopia. We have a number of things that we can point our fingers at based on animal models, based on human studies, but we really don't know what causes myopia. We certainly have a lot of ideas about the origins of myopia. One of the bigger ideas are the genetics. You know, how is gene therapy going to be affecting this in the future? I don't think it will, because there's a number of different manifestations of myopia into this. We all have an idea of how to manage myopia from an optical perspective. You know, anything from increasing outdoor activity to using single vision lenses under correction, so on, so forth. But the reality is that we're doing these things after the fact, after the patient has been diagnosed with myopia. So welcome to my world. I was talking with Dr. Samuel. I had a meeting in my office with a mother with her child, 7, 8 years old, and it was a -6. And she asked me point blank, is there something you can do for my child? Now, that touched me in two ways. As a father, you know, I can understand the plea of a parent trying to do something for their child. As a clinician, I had no answer. And that's when I decided to seek answers, because, you know, telling them, well, you know, we can wait until she's 19 years old and get LASIK, it's not an option. So I started looking at studies, and the first thing that I need to realize is I need to understand the study designs. Once again, I'm a clinician, I'm not a researcher. So you need to look at things, if it's a prospective, is it randomized, is it controlled study? What type of study design is it? Seek a mentor that's able to help you identifying these critical things on reading a study. But ideally, what we want to do is we want to detect the child at point A. We want to give him a therapy, and we want to give him a discontinuation date for that therapy, and we want no measurable change in the rate of myopia progression. You'll see the rate of myopia progression be disclosed as a ROMP, R-O-M-P, okay? While the control group continues to increase. That's the idea, that's what we love to see in managing myopia, but that's often not the case. What we actually see is that there's a delay in the progression of myopia. Then we stop the therapy, and a couple of things can do. If the rate of progression can continue similarly as before, or the rate of progression can accelerate. But as long as the difference between the control group and the therapy group is statistically significant, we shouldn't have any problems with that therapy, right? That's what we're trying to do. We're trying to achieve something that's different. But we have to be very careful that if we discontinue the therapy, and we've seen this in a couple of studies, if we discontinue the therapy, that the rate of progression of myopia increases and catches up to the control group. In that case, you know, the study was not effective. But understanding how to read the studies is the first thing. So, once again, I have a lot of questions. I don't have a lot of answers. And that might sound disappointing, but, you know, what do we do with these patients? Well, let's look at some strategies. Number one, we can look at hypotension, decreasing the pressure of the eye. There's two theories here. If the pressure of the eye is elevated, it's going to push back, it's going to create axial length, which is actually going to create myopia. On the other hand, if the eyes are converging and the child is looking at doing their homework 5 hours a day, which I don't know of any child that does homework 5 hours a day, the excessive accommodation or the convergence can increase the intraocular pressure and then driving the actual length, the back. Either way, when there's an increase in pressure, there's a stretching of the sclera and there's an increase in actual length, increasing the myopia. So let's look at hypotension. Let's look at lowering the pressure. It makes sense, right? So we can look at beta blockers and we can look at prostaglandin analogs, and there's several studies. Most of them have no controls. Most of them are not randomized. So right from the get-go, maybe it works, maybe it doesn't work. Well, if that held true, in this study, the reason Blanchard did the study is he says, well, if we lower the pressure, then the shape of the cornea should change, right? If that's the reality, I mean, we're working backwards. Well, the shape of the cornea does not change when you lower the pressure. So that takes a little bit out of it. But we have a number of studies looking at hypotensive therapies at controlling myopia. Most of them are questionable at best. Some of them are better than others. There's a study from Jensen 1991, 150 Danish kids. It lasted for 2 years. It compared timolol 0.25% versus spectacles. As you can see, there's no difference in the rate of myopia progression at 2 years between the timolol group and the glasses group. So that takes pretty much timolol out of the way. But even though there's lack of evidence supporting this hypothesis, there's a number of animal studies that do support the hypothesis that decreasing the pressure does help in controlling myopia. One of them is Dr. Liu in guinea pigs. The other one is Dr. Elminori, also in guinea pigs, and they're able to control myopia progression using both beta blockers and prostaglandin analogs. So certainly something to look forward to. But the reality is that animal models are a starting point for clinical research. Once again, from my perspective, I'm a clinician. I want to know how to help my patients. Animal studies are useful, but they're useful for basic science. They're not useful for clinically applied science. But if we look at animal studies, they're extremely valuable. We have pyrazipine. Pyrazipine has been shown in animal models to decrease or block axial length elongation due to form deprivation. So what did is that there's two very good studies using pyrazipine 2% ophthalmic gel. The first one was by Zitowski, and this study was 174 patients, ages 8 to 12. The spherical equivalent, the spherical equivalent refraction was between 0.75 to 4. So mild to moderate myopes. 1 year period, 13 academic institutions. Actually, Gary Novak, a really good dear friend of mine, was involved in this. He's the last author. I think he didn't do much. But what they did is they randomized patients. Well, surprise, surprise. The pyrazipine group increased a quarter diopter over a year. The control group increased twice as much. It was statistically significant. There we go with the p-value, which is important, okay? So what about or stopping the medication after the therapy is complete? Well, 2% of the pyrazipine group increased more than 1 diopter after 12 months versus 20% of the control group, which increased more than 1 diopter after 12 months. So that gives you an idea of how effective the medication was. The second study was by Dr. Tan. Dr. Tan's an ophthalmologist, is very well known in the pediatric ophthalmology community, using also pyrazipine ophthalmic gel. And this study was carried out in Asia. It's known as the pyrazipine Asian study. And it compared 3 modalities: the placebo, actually it was a placebo-controlled parallel randomized double match study of 353 children ages 6 to 12. It had 3 arms, pirenzepine twice a day, placebo in the morning plus pirenzepine in the evening, and placebo twice a day. So this is a very well designed study. And what they wanted to do was measure refractive error and actual time. Well, surprise, surprise. The rate of myopia progression at 12 months for the pirenzepine group was half a diopter. The rate of myopia progression was almost double that in the control group. So that's telling you that this medication is working. Regretfully, pirenzepine has not been studied because of the side effects. In both studies, roughly anywhere between 11 to 13% of the participants have to discontinue because of adverse events. Once again, it's important to understand the science, it's important to understand the study design in able to extract information. So we move over, and actually in the actual length in the pirenzepination study was also significantly different in the study. So we have another pirenzepine. I think actually pirenzepine as a side note, I think is going to be extremely useful going forward as we're starting to use polycarbophyll and niacinamide seals to deliver medications to the eye. I think that the way we deliver medications to the eye does affect the way the medication works in a number of ways.